Hello and welcome to this special EULAR review podcast brought to you by the Lupus Forum. My name is Ed Vital. I'm a professor in translational medicine at the University of Leeds in the UK, and I'm the chair of the steering committee of the Lupus Forum. And today I'm joined by Professor Chris Edwards, who's a consultant rheumatologist at University Hospital Southampton NHS Foundation Trust, and honorary chair of clinical rheumatology at the University of Southampton there. Welcome, Chris.
Hi Ed, thanks for asking me to join.
And how did you find it? How did you find EULAR?
Yeah, I really enjoyed it. I mean, you go to some meetings, you think, oh, did much change? It's sort of lots of post hoc analyses, but I thought there were lots of good sessions.
Yeah,
I thought there were a few new drugs, and
yeah.
of course we've got all the CAR T cell engager stuff going on.
Things are
Um,
moving quite fast, aren't they?
yeah, and so
So,
I felt really optimistic about it. Yeah.
me too. So, as always with these podcasts, we're going to discuss what we found most interesting at EULAR. There's lots of lupus content, and we're not going to cover all of it today, but the highlights brochure is still online at the Lupus Forum. So there's over 30 abstracts there from across the conference, which cover a wide range of topics and therapeutics. And also, if you want to be informed about similar content of key abstracts for rheumatoid, psoriatic arthritis, axial spondyloarthritis, and scleroderma. There's highlight brochures on the IMID forum and on the scleroderma forum, respectively. So anyway, let's get into it. Chris, what were your best highlights?
Yeah, so if I talk about some of the overarching lectures just a little bit first of all,
Yeah,
and then maybe we can sort of move into some of the abstracts. So there was a What's New session, so a WIN session that Antonis Fanariakis presented. And the reason I like that was because it went through a little bit about pathogenesis and what's happened over the last year or so, a little bit about treatment strategies, and a bit about major clinical trials as well. So tiny little nuggets that he mentioned were around the increased genetic burden you have of genes associated with lupus, the higher your ANE titer. So it was just showing a link between the genetic load and an immunological phenotype. I saw some of your work was presented in that session around the interferon signature predicting progression for
yeah,
patients who are ANA positive. So that sort of stuff. And then there are little snippets that are mentioned around treatment, hydroxychloroquine. We always think it might improve lots of things and improve mortality overall. But there was some French data around reducing hydroxychloroquine. But some of those things have been presented already. One of the things that I thought was really interesting was the presentation by Laurent Arnaud, and he was looking at this concept of more unusual manifestations of lupus. And I guess when people do trials of lupus, they do skin, they do lupus nephritis, and then they tend to be lupus studies. So we're often pretty devoid of data that allows us to know exactly how to treat people. So this was a joint effort that he talked about. It was ERN-RE Connect, Reconnect, the SLIC group, and the SLE Euro, so the European Lupus Society, effectively.
yeah,
And just very briefly, they did it really nicely. They got experts together and they decided what were the important things. They decided in the end 24 were the most important that they would deal with first of all. And they're things like neuropsychiatric lupus or something I saw when I worked in Singapore, lupus enteritis, so lupus gut disease. And then they got the experts to come up with, they'd already done a literature search, which they updated. They got the experts to say, how would you treat these things? So lupus enteritis, for example. This is our top one we'll vote for, but there's this option and then there's this option. And it was a really nice approach to looking at some of these really difficult things that don't always have evidence. So, I mean, that's a publication now in
yeah.
like
I, I,
rheumatology, isn't it?
yeah, I was involved in that actually.
Yeah, I
So
thought you would be.
basically, the way it worked was really good. You had to say, I've got personal experience of this treatment regimen. This
Yeah.
was what my experience was. If you've got any papers or case reports, you cited those. So basically, we all really put our evidence together and then we voted on what everyone had submitted to see what came out top. And the first paper, like you say, has come out in Lancet Room. And they did a bit of a deeper dive into some of those difficult subjects at the conference. But there's also a round two coming. that's going to have a load more of these rare
So
manifestations.
that beyond the first 24, is it? That's the other
Yeah, so like the more
sort of feature.
features we've been asked again. So it's, and I have to say, having like probably like you, we do a multidisciplinary meeting and where we people bring their complex cases and we put our heads together. And usually there's no evidence, but we try to say what the best we can is. And I've already used that paper in that meeting. I was lucky enough to have a copy before it was published, but I've already told people, look, well, it says here that somebody's used this and it worked, and somebody's used that and it worked. So really is a good resource.
Yeah, yeah, and I think Lauren, when he was presenting, I said, is this right? He said, at the moment, it's free to download if someone wants to go and look at the paper, and I think that's for a month. So
Right.
it's
Okay.
interesting for
Yeah.
people to have a look at it. So I downloaded the PDF quickly and stored it
Yeah.
on my
Right.
desktop.
Good.
Um, and then there were sort of posters and things. I don't know if there are specific abstracts that you want to go through. There was a clinical poster tour session
Mhm.
had cenerimod in it. So this is a phase 2 study. So it's a selective CYP1 receptor modulator.
Yeah.
And done some extra work on it. And it was just some little bits of sort of nuggets in it, I thought. One is they modified the SLEDAI score that they used because you'd expect cenerimod to lower lymphocytes. So they didn't want to include that. So they stripped the lymphocytes out of it. So I thought
Yeah.
that was just interesting. And then they showed some data around sustained response and showing that the cenerimod was effective compared to the placebo, so 63.5% versus 50%. So that was the first one
Yeah.
I looked at in terms of newer mechanisms of action
And
and a molecule that's having an effect on
yeah,
lymphocytes getting into
it's
tissue.
basically stopping lymphocytes
Mm.
migrating around,
Yeah,
which is why it affects the lymphopenia so much. But the interesting thing about it is you might think this is an immunosuppressant that could work for all sorts of conditions,
yeah,
actually, all sorts of autoimmune diseases. Multiple sclerosis is one of the other ones. But so, if it's gone to phase 3, and if it
yeah, yeah.
succeeds, it's something you could see quite a lot more of in future, potentially.
Mm. So what about you? Did you see any
Yeah,
abstract?
so other therapeutics wise, there's a few that are looking promising, and another one that's looking very promising is dapirolizumab.
Yeah,
We've mentioned on Lupus Forum a bit before, so this is the CD40 ligand pegylated biologic, which is originally we thought of CD40 ligand as a BT crosstalk molecule, a bit like co-stimulation blockade with a bataset, but actually it has lots of other functions in the immune system. So there's quite a lot of potential effects this drug could have that could be useful for lupus. And the phase the phase 3, this is a phase 3 trial. So it's a high level of evidence, actually, and it met its primary endpoint, which is BICLA at 48 weeks. It didn't quite meet one of the secondaries, which was the 6-month BICLA, which is unfortunate because that was high up in the hierarchical testing. But
yeah.
then when you go down all the other secondaries, there's lots of positive things there as well. So there's a few things that stood out from this conference about it. So one thing that I was presenting was that although it takes a little bit of time for the clinical efficacy to come in, like BICLA SLEDAI efficacy to come in, the steroid sparing was seen as significantly different or nominally significant as early as week 8. So
Mm,
it's doing something quite fast,
mm,
actually,
mm.
which is interesting because we haven't got very many drugs that work fast, but that actually suggests it does do something. There's this interesting trade-off in the trials, actually, which is obviously if you get the physicians to bring down the steroids, then you might blunt the efficacy difference. If or if you do the opposite, so there's trade-off. So if you do trials where you say investigators can do what they want, lower steroids when you feel confident,
Mm.
then you might see steroid doses come down faster in one arm than the other. And that's kind
Yeah.
of good signal. Although, that, the other hand, you could say everyone's got to lower steroids at a certain time. And if you do that, you won't see a difference in steroids between the two groups, but it might come out in the efficacy of that. So,
Yeah. Well,
anyway,
probably it'd be nice to have different studies designed to show both of those things, wouldn't it?
yeah,
And
that
then
was an interesting,
overall,
and different trials have gone different ways.
yeah.
then another thing that came out of it that I was really quite impressed with is they had a separate poster talking about fatigue.
Yeah.
So it's always really hard to show fatigue improvements in lupus trials, even though we do think these drugs can work for it. It's really hard to show it. And here they use typical fatigue measures like FACIT and things, but also a novel fatigue PRO, so a new outcome measure for fatigue that had been developed for this and did show quite a big difference between the two treatment groups. So that's something like we really need drugs that
Yep.
work on fatigue. So and then they had something on sustained remission, sustained LL-DAS as well, which looked very positive. So
Yeah, I think was that was Eric Morand, wasn't it?
yeah,
Presiding?
that the
Yeah,
the,
yeah,
the the LL-DAS data got presented as an oral, and the
yeah, yeah,
primary
yeah,
endpoint was actually a poster, funnily enough. But
yeah, yeah, yeah. Okay, yeah. Okay.
yeah,
Okay, and then there was a bit more data around upadacitinib as well, along
yeah.
with elzabrutinib as well. Joan Merrill presented that, but they had 104-week data. And I guess with anything that's a bit JAK-like, then we look for VTM MACE. So there weren't VTM MACE events that were reported. So
Yeah.
they said there were no new safety signals, and had continued to have the effects on disease activity that you might expect. But we need the phase 3 studies to.
But those all those three drugs we've mentioned are in phase 3 now.
Yeah, 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 absolutely right. So there was that. I'm just looking through before we
And
get on to cut. Oh, I know what else. I mean, this isn't quite the new bit, but Marta Mosca presented real life anifrolumab data, and it's just these phases of drug development, are there? You get the early phase, then you get phase 3 regulatory type studies, and then okay, and in real life, with all the extra biases and problems that are in real life data. And Marta presented that, and she was showing remission 10% at 3 months. No, yeah, Doris remission about 19% at 6 months. That's right. So 10% at 3 months, 19% at 6 months, which never sounds that it still sounds not that good, doesn't it?
it always
And I
seems
don't.
better in reality than the trial
Yes, exactly.
suggests. Yeah.
And maybe it's because we have patients that respond really well and we continue, and the ones that don't do so well, we do something else. Maybe that's the
Yeah, or
case.
maybe we're better at picking who really needs treatment in our clinics
Yeah,
and
yeah, yeah,
exactly
yeah.
when it needs to be given and things like that, whereas trials have all these restrictions and
Yeah,
things like that.
absolutely. And then did you see any of the CAR T stuff?
Lots of, I mean, yeah, there's lots of discussion about it. Several abstracts. Still, most of this is telling us very early phase, open label. So like there was one presented by Eric Morand about a product called YTB323, which is a rapid generation CD19 CAR T, CD19 again. They presented data from 13 patients, but 10 of them had less than 6 months of follow-up.
Mhm.
Average follow-up 4 months. But the other three who had longer follow-up, good efficacy, one grade one ICANS. Interested to
Yeah.
say, like, this is important because initially we said with CAR T that in hematology, cytokine release syndrome and ICANS are both two potentially very serious toxicities that we think we're seeing less often in autoimmunity, bit like we do with rituximab and obinutuzumab. You see less of it because you haven't got the tumor burden, you haven't
Yeah,
got
yeah,
as many
yeah.
cells to kill, but it's not nothing. And ICANS can actually occur even without a heavy tumor. But the hematology experience is with the relapses when the tumor burden might not be as high, they still can see these things. So
Yeah,
there
yeah.
is a grade 4 ICANS reported last year, which is quite nasty. There was one grade 2 here, only one grade 2. And then there was another one I saw called the Castle study, which is another CD19 CAR
And is that
T.
the carry on from is that the Erlang and stuff, the Castle study? Is that different?
This was a separate one,
Okay, different. Okay.
and they had no ICANS, some grade 1 and 2 CRS, but no 3 or 4, some significant neutropenia, and they've got a mixture of lupus, myositis, scleroderma. So
Okay.
they've got week 24 data saying that Um, the lupus patients, 7 out of 7 got Doris remission, about as
Yeah.
good as you can get. Of the myositis, 2 out of 2 got a moderate or major response. And of the sclerodermas, 6 of the 6 had no worsening. So all seems
Yeah,
promising.
yeah. And
Yeah,
actually, in those sessions, so one of the sessions, the basic and clinical poster tour, there was a CAR T cell and emerging therapy poster tour, and there were 7 posters they'd selected. It's just interesting to look at the different approaches. So there was a CD19 CAR T, there was a BCMA CD19 CAR T. Then people start to talk about the off the shelf. I'll come back to that in a moment. CAR Ts, there's sort of different approaches. There was
yeah,
some T cell engager work, which some of us are starting to do some of those studies on the basis that might be a little bit less aggressive than CAR T,
yeah,
but
yeah,
similar approach and more off the shelf perhaps. And then there was some nice stuff on one of the posts, and it was talking about the idea of next generation multi-antigen CAR T, and there were various things. So choosing different antigens, but then it was, I mean, the engineering beyond this is just completely incredible to me. You then put things on the cells that allow them to traffic to the correct place in the tissue. So that's the first thing.
yeah,
And then you eliminate the conditioning chemotherapy because you need to, in traditional CAR T, give chemotherapy to stop the reaction of lymphocytes against the CAR T cells.
yeah,
And they were engineering to put on proteins that would resist that alloimmune cell response as well. So you're starting to get, you're not just taking a cell, you're not just producing a receptor to bind to something, you're not just making it activated, you're now allowing that cell to go somewhere and not to be depleted by the local immune system. I mean, that to me is just
yeah,
is like Lego, isn't it? With
yeah.
Lego immunology. It's incredible.
It's amazing. I mean, so some of the next generation approaches are getting really sophisticated. Um, some of the conversations I had several times with people asking me about it, like one is basically you've got some of the you can go after CD20, some of the bispecifics go after CD20, same target as rituximab, obinutuzumab, um, and that's targeting B cell plasma cells. Then CD19, which we've already heard data about, the Erlangen data and the other studies we discussed, is targeting plasma cells a bit more,
Yep.
which may be why you get more antibody conversion, becoming seronegative. And BCMA is really targeting plasma cells.
Mm.
And I guess my feeling is if you're doing a one-off treatment that's trying to do this so-called like immune reset, then you kind of want to go as deep and probably into the plasma cell part
Do.
as,
But it
as
gets a bit
possible.
scarier. But
You
it gets a
really
bit
want to.
scarier though, doesn't it?
But if you want, and if it's a one-off, that's great.
Yeah, yeah.
But if you think that these people might relapse at some point and you might have to do this again, then probably you need to be a little bit more cautious about targeting plasma cells, I think,
Yeah.
is my
Yeah,
feeling. The
yeah,
fact that you
yeah.
might need to do this again, a lot of this was discussed, that the whole thing is based around the theory that lupus is a mistake that B cells made, that if you put it right, it won't happen again. Um, but there were some sessions. There was a great session. There were some talks about like non-B cell components of lupus pathology,
Yeah,
innate
I
stuff.
saw that. Yeah, yeah, yeah.
Yeah, and it's like, like actually you can see a completely different argument saying it will come back. It's
Yeah, it
just
was not all about B cells, myeloid-related inflammation in
eh,
lupus pathogenesis. Yeah,
exactly.
yeah, yeah, yeah. That was
And
all.
some of those genetic stuff you were saying. So all those people will say, oh, these are mechanisms that'll bring the lupus back in the end. Maybe it'll take a long time. Hopefully it'll take a long time, but in the end, the disease will come back. So we really, we're guessing, we're speculating,
Yeah,
but that's another thing that came up a lot. I was finding myself in a lot of discussions is people are interested in saying, actually, if we say it goes deeper and it depletes in tissue, show that. So biopsy the lymph node and show the B
yeah,
cells gone. And and people have started to show that, although then I heard people saying, well, B cell activation in lupus might be extrafollicular and it might not be in the lymph node. And is that really the target? Which is a fair point.
yeah. And so does
Um,
that mean you need to get other tissues, or
Other
do you
tissue,
need
it
to
could
get
be
all blood in
elsewhere,
cells?
yeah.
Yeah, 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 okay.
And then people saying, well, what about in the kidney biopsies? Do we see B cells in the kidney? It's like, well, I don't know. Is that where they need? I don't know. Antibodies circulate. Do you have to, So these are all interesting questions.
But what's amazing about all the CAR T and this sort of stuff is that is all the insights it gives us about the mechanism of disease as well. So there's of
Yeah,
course, we want to
exactly.
treat people, of course, we want to do it safely, but this starts allowing us to take out little bits of the immune system in quite deep and profound ways and say,
Yeah,
okay, now what happens? What does it
exactly.
do to the disease and what it tells us?
And there was a bit of, I mean, there wasn't so much of the primary data at this conference as at some previous ones, but still there was a bit of data on and some discussion symposiums and things that we can't ignore on the other two B cell depleting drugs that are right up there. So obinutuzumab
Mm,
recently got a positive trial in lupus nephritis, going through regulatory approvals, non-renal trial in progress. I presented a bit of the biomarker data there, and ianalumab, the BAFF receptor, but still depleting B cells, another monoclonal antibody that's in phase 3. So whilst these T cell engagers and CAR Ts are being developed, you've got these other two B cell depleting drugs that are better than rituximab that are coming up quite fast.
okay.
Yeah.
Well, mentioning rituximab is a good sort of leader because there was also the Biologics Registry trajectories data.
Yep.
So they look at people's response to rituximab. They use a machine learning approach, and then they try to look, can you divide this up into different trajectories and what predicts it? And it's always nice when the prejudices you always have about response are fulfilled by some of these studies.
Yeah.
So
Yeah.
the thing that stuck out from that for me is that the people who had anti-double-stranded DNA antibodies tended to respond more likely than groups like those that had anti-RMP. And sometimes the
Yeah.
anti-RMP ones for me are the more resistant with rituximab. That would be
I agree.
a prejudice
Yeah.
I already had. Uh,
Yeah.
and there were some other bits about trying to look at multi-omic approaches to try and say, if we measure these things, can we predict response? I mean, that's not there yet, but people are playing with those things and trying to decide
Yeah.
if they can help. Did you see there was everybody's talking about anti-obesity drugs now at the moment? There was a clinical abstract on this, and it was US data. They had quite a
Yeah.
lot of people in these groups, people with lupus nephritis, and they were divided up into people that had been on GLP-1 agonists, so the
Mhm.
anti-obesity drugs, and SGL2, so the sodium glucose transporter, which is often given to people with renal disease, perhaps patients with lupus nephritis. And then they looked at what happened to them over time. And the ones on the anti-obesity, the GLP-1 agonists, they had less myocardial infarctions, they had less mortality, and they had less lupus nephritis. It was better control, less progression, less renal progression. Now, you might just predict by making people lose weight, that's likely to be a good thing, and therefore everything gets better. But compared to the SGL2 inhibitors, which in my mind is a much more let's use in renal disease,
Yeah.
the people on the GLP-1 inhibitors did better. It wasn't
Interesting.
that the ones on the SGL2 did badly, it's just the ones on GLP-1 did better. So it was just, it makes you want to, I wonder what that's about, or whether it's just such a good thing to take away both the physical presence of adipose tissue, but also its metabolic
Yeah.
activity,
Yeah.
that you just do other things that you're not expecting.
That's another nice link, actually, because we had the EULAR lupus nephritis
Yeah.
guideline update presented. So this one doesn't have an abstract. It was in the guidelines session, but it's still visible online on the Friday afternoon guidelines session presented by Dimitros Bumpas. So again, background on this is that there's therapies coming through trials. So we had belimumab, I think something like 2018, as a combination therapy, and then voclosporin shortly afterwards, then obinutuzumab, like I say, this year. So that's leading to updates of guidelines coming out quite fast at the moment. So every few years we get an update. So we had the ACR guideline updated last year. You and I have just done the British one, including an update for lupus nephritis. And here's the EULAR guideline for lupus nephritis. So a few things in there. One thing is combinations coming up to first line now. So we had this, I think the old guideline, we had a slightly strange situation where you said you could have mycophenolate combined with belimumab or mycophenolate combined with voclosporin, or you could just use mycophenolate on its own. And they're all kind of there equally as first line, which is something I really liked because I sort of thought, well, if you do an RCT and one arm's better than the other, you should probably stop recommending the worse up. So I think they still allow the option that maybe you might use a single agent in some cases, but the combination is far more up there. Steroid dosing, I think, has changed a bit. So it says use IV and then zero point 0.3 to zero point 0.7 milligrams per kilogram. There was
Yeah.
a new bit in there on the non-immune therapies. That's why. So salt, low salt diet, ACE inhibitors, lipids, bone protection, and like you say, SGLT2 inhibitors
Yeah.
being
Yeah.
mentioned in there. Um, so the paper I expect will be out quite soon with that update.
Yeah. And then, I mean, just thinking about, so there were a couple of other things that were around. I was trying to find it. Maybe it's around I think there were a couple of abstracts around steroids. So this isn't directly related to lupus nephritis. So I'm going off a bit off piece from I'm
Yeah.
trying to stick to exactly the same theme you're talking about. The other two things that I picked, one is glucose tapering. So there was a poster.
This was the one I presented.
No, this was the one
Was it?
about from Japan. This was chart review in Japan,
Oh,
glucocorticoid
okay.
speed and renal outcomes. So then tell me about yours in a moment. And it's about so it's always interesting to try and decide how aggressively we should taper steroids. So all my career, we've tried to reduce steroids. High dose for long times bad, medium dose for long times bad, and now we get to this bit where everyone's trying to stop them completely. But I still feel that there's a group of people that with low dose, they just need to be in a bit of steroid and the risk isn't too great. And this Japanese group looked at people who'd tapered rapidly to less than or equal to 7.5 milligrams, still a bit high for the level we might be aiming for, and showing that that didn't lead to a particular flare, saying you can go much more quickly. It's not necessarily the taking it all away, it's just the getting down quickly
All
that's
right. I see.
important.
Yeah. Get down to
And
the safe zone as fast
yeah,
as.
yeah, yeah. And
Yeah.
and to me, the safe line is, is probably five or less
Yeah.
rather than 7.5 or less. Yeah. So tell me about
So
the
the
one you.
one I did was so there's this there's this effort called Transform Lupus, which is funded by AstraZeneca, but it's actually not anything to do with anifrolumab. It's one of these like above brand things
Mhm.
that's just trying to improve the care of lupus overall. And so one of the things we did was we said, how can we make steroid use better in lupus? We reviewed the literature a while back. This is already published, and said, like, although all these there are guidelines that tell you to use less steroids, sometimes they're not that specific on exactly how much and how quick. Not if you compare to, say, I don't know, like the Pexivas came out with a very specific protocol, didn't it? So we don't have so much of that in lupus as they do for vasculitis. So guidelines are a bit vague on the actual numbers. And then the other thing is that the feeling is although the guidelines say these are the targets and things, they're not always achieved or followed in practice. So we sort of said, how could we really make a real change the way we use steroids? And the idea was to produce a set of guidelines through a Delphi process, just like the EULAR one we just talked about. In other words, get experts to propose statements and get a big group of clinicians to vote on them. So we had a steering committee who proposed the statements and about more than 100 people all over the world voting on them and going in rounds until we got something that people could agree. So there's a various statements about steroid use in there, but then a particular product was to say, let's come up with some off-the-shelf regimens that you can just choose and follow. So a lupus nephritis patient or some other severe lupus patient, here's a regimen. A moderate patient, like you say, here's another regimen, starts a bit lower and comes down, or a mild flare, or something that starts very low and is quite a short flare. And the idea of doing that was that if those are all available, then you could say to the patient, here's all your steroid doses for the next 8 weeks or 12 weeks. Do this for these weeks, this for these weeks, all there printed. That means that it's easier for the patient to follow. It's also easier for doctors to follow because we often make ad hoc decisions, don't we? We say sort of, we'll take this for 15 milligrams and next month I'll decide what to do.
Yep.
And then they see your colleague or something like that. So having it all planned in advance is believed to be a strength. You may deviate from it, of course, but you still have a plan.
Yeah.
And the
I think
idea
that
being, of course,
yeah,
that if
sorry.
you do that, you won't end up in that situation so often.
Yeah.
I take your point, to be honest, that if someone's been on 5 milligrams of prednisolone for 3 years, is it really worth trying to stop it? Are you causing more?
I mean, I always want to stop
You
it.
always want to,
If
but
people who've had,
if you tapered it in this sort of planned way, it might happen less often,
yeah,
actually,
yeah,
because you
yeah.
wouldn't lead to, yeah. So
But I think having the strategy to reduce or stop makes a big difference. And there are,
exactly.
we could borrow from the rheumatoid data some of the systematic reviews that went into the recommendations the last time. If you have a strategy of how you reduce, you reduce. If you
Exactly.
don't have a strategy, you don't.
So
So,
getting anyone to agree on the numbers is hard,
yeah,
but at least it changes the way you do it, the way you approach it. Have an extra strategy from the start. So that's almost finished that project. The last part is to get some patient input on it, and
absolutely.
then we'll hopefully get into some dissemination efforts to try and get that into practice. So perhaps we're almost out of time, but we have to do a late breaker.
Yeah.
Um, and there was a late breaker for lupus, which is always exciting. So we've already said you've got CAR-T in early phase, we've got DAPI, we've got cenerimod, we've got upadacitinib, deucravacitinib, all those are all in phase 3. We've got obinutuzumab, ianalumab going on there. But there is another drug that came in at the last part of the conference, which is empataran. So empataran this is a positive phase 2 going into phase 3. So this is a TLR7 and 8 inhibitor. So basically, on the innate immune side, the pathway goes, you've got self-nucleic acids, DNAs and RNAs, that's your antigen. Those get detected by nucleic acid sensors. So you've got TLR7, 8, 9, or some other molecules like C-gasting and RIG-I and things. So these are all molecules that detect these antigens, nucleic acids, and then that leads down to an interferon response and everything that follows from that. So it's a bit like going a little bit higher up in the pathway than we do when we target interferon or JAK-STAT pathways, more at the real detection of the antigen in the first place. And so this trial had quite an interesting design because this phase 2 trial had 2 parts called cohort A and cohort B. So cohort A is actually a kind of basket study. So it's about skin lupus. But what they said is we don't care whether you've got skin lupus as part of SLE or if you've got skin lupus, in an ANA negative person who hasn't got SLE. So this is a combination of a sort of dermatological clinics and rheumatological clinics, just with the common feature of skin lupus. So that was presented actually before, and that shows a really big CLASI response. So really good efficacy. And then what was new here was the cohort B part, which is a bit more typical SLE, BICLA endpoint, so lots of skin and joint disease. So that one was effective as 2. And the other thing you saw is that actually, this is again mechanistically interesting, is that it totally wipes out the interferon signature, which I don't think everyone was sure about because, like I say, you've got TLR7 and 8, which is being blocked here, but you've got TLR9, you've got C-gasting. There are other
Mm.
ways into the interferon pathway that actually turns out blocking TLR7 and 8 really works. So that came in at the last minute, and that's going into phase 3, which looks very promising.
That sounds like a perfect moment to end, I think, with a late breaking
I,
out.
yeah, exactly. So that's all we've got time for. So thanks very much for all that, Chris. And I hope everyone's enjoyed this podcast. If you don't forget to visit the Lupus Forum, lupus-forum.com, you can find lots of other lupus content. So there's detailed slide decks of the top research. There's monthly podcasts of papers that come out every month. And there are these special webinars around key topics of interest. So thank you. And as always, best of luck in your clinical practice.
Thanks.